Okay, fine. Let's discuss clinical topic, which is basically this is also called Wellen syndrome. Wellens syndrome. Wellens syndrome is basically clinical, you can say, findings in which we see in typical V2 and V3 having biphasic T wave, or you can say deep and inverted T wave. Biphasic or inverted deep T wave, right? And it indicates particular some things that we are going to discuss basically. Yes, and in this case basically patient having recent history of angina or chest pain, and patient maybe have or maybe not having you can say biomarker, that is tropi, right? Maybe normal or maybe elevated, or ST segment maybe you can say normal or slightly elevated. These are the you can say topic we are going to discuss. But yes, let me discuss. We just recently discussed about the LAD, right? So this is LAD, right? This is left anterior descending artery. So this is clinical sign. Basically, if LAD is critically occluded, suppose this is LAD and it is basically critically occluded. Right? If LAD is critically occluded, and due to even you can say dynamic alteration in this atheromatous plaque or calcified plaque, or you can say localized tissue oxygen demand is increased, then what will precipitate? Ischemia, or you can say angina. Hello, what will precipitate? Angina. So clinically we see patient come with a classical sign of like chest pain and perspiration or diaphoresis, and then patient, when patient go to the clinic or you can say hospital, doctor do 12-lead ECG, and ECG so some typical changes like okay, I'm going to draw pattern. This is I'm going to draw Wellens pattern. See, this is T wave, this is QRS complex, this is ST segment, maybe not, but this is ST segment, and this is okay, this is significant. Let me so this is biphasic T wave. Hello, biphasic T wave. And another pattern we see basically, and we are talking about specifically lead V2 and V3. V2 and V3. Yes, another pattern. Okay, this is called type A pattern. Type A Wellens pattern. And type B is having basically having, yes, which type of pattern? This is P wave, QRST, ST segment, and deep inverted T wave. Deep inverted T wave. This is called type B, and this is deep and inverted T wave, right? So if patient is having critically occluded you can say left anterior descending artery, and patient has not done undergo any type of investigation, patient suddenly develops sign and symptoms of chest pain, diaphoresis, and classical signs. And if you do, and then once patient come to you, at that time patient is basically symptomatically perfectly okay. Now, right now, patient is having no sign and symptom, and you do ECG, and ECG show if in V2 and V3, and up to in some case even V1, and up to in some case V2, V3, and V4, you see this pattern: biphasic T wave or in deep inverted T wave. Always think of the critical occlusion of the left anterior descending artery. Critically occluded, you have to think about the worst about the patient, because it is the indication of patient may be having recently you can say total occluded event, cardiac event, coronary artery you can say event, or there is high chance you can say spontaneous clot lysis is done, spontaneous fibrinolysis, that we have endothelial lining have so many clot preventive mechanism we have discussed in very detail, right? Or if patient has taken pre-hospital aspirin, there is chance if platelet plug is there, suppose platelet plug was there and now LAD is critically occluded, complete occluded, patient will develop what classical sign of anterior MI, and ideally there should be if ST segment will start elevation, so slight elevation in ST segment. And yes, if due to pre-hospital aspirin or spontaneous lysis, if this clot is removed, then you can say compromised perfusion will be, otherwise reperfusion will be start, and patient will develop you can say disappear all the sign and symptoms. But what patient will have in ECG point of view, biphasic T wave or deep inverted T wave in V2 and V3. And if you feel if patient is having recent sign of angina or chest pain, and you do ECG and you see this sign, then you have to think about the critically occluded LAD, like critical stenosis of the left anterior descending artery. Then you have to don't wait for the you can say the next episode. Okay, this sign also indicate that patient will develop reinfarction within coming few days or within coming few weeks. So why should we wait for the reinfarction? Ideally, we should go for the angiography, and if critically plaque is there, then we have to go for the PCI, percutaneous intervention, whatever they require, balloon inflation or stent or bypass, whatever is required, right? So you can save the patient by just you can say uh, by the ECG findings, right? Yes, what are the you can say? Okay, let me see discuss the scenario. I am the patient and I have a critically occluded left anterior descending artery, right? And dynamic alteration or platelet plug is formed here, and now I am having classical anginal attack, and I have diaphoresis, and I have taken pre-hospital aspiration, and that platelet plug is you can say dispersed and compromised reperfusion is started. Then I will have a right now I will have a no sign and symptoms. I will have a normal RV progression. Basically, in precordial leads, basically normal RV progression is seen. The normal RV progression is there. ST segment on you can say isoelectric line. It is normal, right? And you see this. Before 2 days, I came to you. You took ECG, and I had this pattern. And after 2 days, I am again coming to the you with the sign and symptoms, and you do my ECG, and this time ECG is perfectly normal. You are having this pattern. Compare this pattern with this pattern. What you will think?
that reperfusion has been achieved.
But I have already come to you with the sign and symptom, acute sign and symptoms.
You can anytime have the another episode.
Nee. See, what this sign is indicated that patients, you can say LED is critically occluded.
Yes.
And now, and you have my previous ECG, and I have this type A and type B Wellens pattern. And now I'm having chest pain and general attack, and you do again ECG, and my ECG is showing T, you can say positive T in V2 and V3.
Is it positive or tall?
Right now it is positive T wave. See, this is biphasing, this is negative, but here none of them. Here is basically normal upright T wave. What should be the interpretation by the doctor or diagnostician?
You must have taken aspirin at home.
It indicates, this is called, either way, it is called apparent pseudo normalization of T wave, and this is most worst condition. Patient is having developing myocardial infarction. Basically, in myocardial infarction, what mechanism is that? Let me discuss. If critically LED is blocked, then Wellens pattern will be seen. And non-case of you can say Wellens sign patient, now you see upright positive T wave that with the sign and symptoms, right? Or ST segment may be slightly positive, not more than 1 mm, you can say less than 1 mm, right? And even normal R wave progression is there. Cardiac biomarkers may be negative, may be positive, but if you see this, then this is a marker of developing myocardial infarction. Why? Because in developing myocardial infarction, basically T wave goes up, and then it will pull the ST segment with it, yes. And then you will have a STT elevation myocardial infarction. But here T wave is basically evolving positive, then later on it will go like this. That, can you say this is developing hyperacute T wave myocardial infarction?
Yes.
Hyperacute T wave myocardial infarction, in specific case this is anterior wall MI, right? So this is this sign is called pseudo normalization of the T wave, and this is a classical sign of developing myocardial infarction, right? Hyperacute T wave myocardial infarction. Making sense or not? Then later on, if patients you can say LED is critically occluded, or you can say totally occluded, then patient will develop full myocardial infarction, and in that case you will have ST segment elevation myocardial infarction. ST segment elevation myocardial infarction.
પેશન્ટ આપણી પાસે ફર્સ્ટ ECG વખતે નથી આવ્યા, એ ફેઝ જતો રહ્યો, અને સેકન્ડ વખતે જે આવે
then you will miss the chance.
I was going to ask this.
So okay, then that's why basically some patient or some doctors say why you need the series of the ECG. I have done before half an hour, then why are you asking for the another ECG after 1.5 hours? This is the reason. Sometimes if patient is having classical sign and symptoms, and ECG is not basically satisfying you, then ideally you should allow, or you should advise for the repeat ECG after few interval, after half an hour or whatever you decide, right? If evolving pathology is there, then definitely you will have you can see ECG changes in your patient. Am I making sense or not? But yes, your question is good. If patient come to you first time and patient is having classical sign and you do ECG having no perfectly okay, even biomarkers is maybe okay, normal ROE progression is there, then you will think that patient is having maybe due gastric problem or maybe due to psychic event, whatever maybe, but this is not cardiac cause. But if you are wise doctor, then you will do repeat ECG after few minutes or after half an hour. Am I making sense or not? and you then at that time you will say if full infarction is developed, then you will see hyperacute T wave and ST segment is getting elevated along with the T wave, right? And you,
condition में sir severe chest pain हो जरूर
patient is having typical sign. Basically, I went for the ECG to the AB Sharma sir clinics. Then patient was having classical sign of cardiac arrest. Patient was high diaphoresis. Patient was sweating and having ghabraman, and patient having chest pain. I do ECG, and patient was having biphasic type A pattern, biphasic T wave. I have learned about the Wellens pattern. I discussed about with the sir. Sir, patient is having Wellens type A pattern. LED must be or maybe critically occluded. Patient should be undergoing, you can say, angiography, and it is must required. Then I just gave a advice. Then I yes, then rest to him. Whatever he discussed with the patient, I don't know, but I gave that advice to the sir, right? So that's all about the Wellen syndrome, right? What are the basically you can say signs, or you can say classical sign where you can say diagnose as a Wellens pattern. So biphasic or deep inverted T waving V2 and V3. You may be slight normal or ST segment, or it may be slight elevation less than 1 mm ST segment elevation. You may have a normal or elevated biomarker, that is tropi. You may have a normal R wave progression from V1 to V5, V6. You see progressively R wave is increasing in voltage, that is normal R wave progression, right? But that this concept was very beautiful, that you know that patient was having type Wellens type pattern, and if patient come to you again with the sign and symptoms and you see that Wellens pattern is disappear and normal T wave is there, then this is a alarm point. This is that patient is having developing myocardial infarction, right? That because T is getting elevated and it will become hyperacute, that is hyperacute T wave myocardial infarction. Making sense or not?
that is the person who tachycardia particularly
Patient will have a developed tachycardia because nothing to do with the synodal and amiral artery. Right? Patient will have a tachycardia because sympathetic nervous system is activated. But yes, it can take your life also because this is a widow maker, right? So if you are not serious about the condition, if you are then okay, we will go for the echo. Echo will nothing reveal, right? But angiography must be. I have so many times I have advised graphy angiography directly. I have bypassed the echo because echo will give you some result after significant you can say damage is there, or you can say initial phase in initial phase structure abnormality is there. Then if patient develop myocardial infection, due to myocardial infarction hypokinesia is there, then 2D echo will reveal that hypokinetic heart. But we want before that hypokinesia develop, we want some signs or you can say proof, right? Let's have ECG study. Let's have ECG.
So, sir, this
Okay.
like what we discussed last, that apparently looking normal ECG, you
Yes.
can still not call it a normal.
Normal, exactly.
So,
And see, let me
dilemma.
yes, let me
Signs
discuss.
and symptoms.
There are so in acute cor
क्लिनिकली तो मैं मैच
yes, clinical judgment is more reliable, and according to American Heart Association, there is a class of patient of acute coronary syndrome which having perfectly normal STT, you can say ST segment and T wave, right? And again they are put into acute coronary syndrome patient.
And biomarkers are also not always
In this case, in specifically Wellens type, if patient is having unstable angina, then biomarkers will be mostly negative because after 4 or 5 or 6 hours later on, biomarkers will necrosis is there. Then after 5 to 6 hours, biomarkers will get elevated. Initially, it will not. See, patient come to you, patient said that I have a chest pain before 15 minutes and you send biomarker. It will 99, more than 99% biomarkers will be negative because that necrotic product of the myocardial cells will appear in the blood after significant damage process is there. Then that take up to some hours, and clinically significantly I am talking that after 3 or more than 3 hours, that biomarker, that is specifically trophi, will elevated in blood, right? Okay, let's discuss ECG. See, we have a ECG, a typical Wellens type A and B pattern. See, in type A pattern, we have biphasic T wave. See, this is biphasic T wave. Here, basically ST segment, then this is T wave, upsloping, then downward. See, A and B, we have basically what? Biphasic T wave, that is Wellens type A pattern. And you can say approximately 25% of case of Wellens syndrome, we find 25% of case in biphasic T wave. And in 75% of case, we see basically deep inverted T wave, right? So in pattern B, basically we see symmetrical deep and inverted T wave, right? So this is classical sign of. So patient come to you, then yesterday I was having chest pain, ghabrament, perspiration, then basically I got normal, but I don't want to take basically you can say risk, please do my ECG, and you do ECG and you have a sign of biphasic T wave or inversion T wave in V2 and V3, then it's alarming. Now onwards you will discuss that your LED must be critically occluded. You go for the angiography, not echography, right? Very good. Next ECG. See, what we see here is uh, here we can see even V1, V2, V3, V4. There is biphasic T wave. But here you can see ST segment elevation in V1, V2, V3, and even V4, and up to some degree V5. So what it means that Wellens syndrome was already there, but now due to dynamic alteration or you can say complete occlusion, now you can say MI is precipitated. Now full myocardial infarction is established. That's why patient is having ST segment elevation, right? But involve you can say culprit artery is LED, right? Very good. And in this case, can you say V up to V5 or somewhat up to V5 ST segment elevation is there? And can we say it is proximal LED as we discussed about the coronary artery, right? Very good. Now you people are becoming pro. Right? Yes, what you see here again, V1, V2, V3, and V4. Here you see basically biphasic T wave, and you will correlate with the sign and symptoms. So patient should have a recent history of angina. Hello, right? Patient may have normal or slightly elevated biomarkers. Patient ECG may be have a normal or slightly elevated, not more than 1 mm ST segment elevation. And this criteria is there, and you will directly send patient to the angiography for the angiography, right? Very good. Yes, again, what about this ECG? This ECG, see, in V1, T is inversion is there, but not significant. But look at the V2, V3, V4, V5, and V6. Can you say it's a proximal LED, critically stenotic, right? Even 1 and AVL also having ST segment elevation. And yes, 2, 3, and AVF. Patient is having basically fascicular block, typically say anterior fascicular block because anterior anterior branch of the left bundle branch or anterior fascicular branch is basically supplied by the left anterior descending artery, and here left anterior descending artery is basically critically occluded. That is patient. That's why patient is having basically anterior fascicular block. Now you are confused. Then what are the sign of anterior fascicular block? I will discuss in next lecture. But we can focus. If patient is having 2, 3, and AVF, basically inverted QRS complex or negative QRS complex. Ideally, 2, 3, and AVF should be positive. Ideally, but that criteria we will discuss in next session, right? But patient is, this is a classical deep inverted T wave, classical sign of what? Type B. Type B, Wellens type B. See here, you can see classical ST elevation. You can STT. This is can you see this is a hyperacute T wave MI and involve see V1, V2, V3, and V4. So this is yes hyperacute anteroseptal wall MI and culprit artery is basically proximal LAD. But if this patient, if you have a history and patient came to you before week, and patient was having sinus symptoms, at that time patient should have which pattern? Rather inverted T wave or biphasic T wave, right? And after 1 week or few days or few weeks, patient may develop full myocardial infarction, right? So is it making sense? So we have another ECG. In this ECG we have, can you say is it biphasic T wave, right? See, we have biphasic T wave in V2, V3, V4, and even V5. That is right. That is again proximal LAD is critically occluded, critically compromised. Directly go to the angiography, not for the echogram, right? Yes, no doubt antiplatelet will help because aspirin will not allow to form platelet plug and little bit blood will continue to drip and patient will have a initial phase basically symptomatically relief, but risk is there. Critically occluded LAD may be completely occluded at any time, right? Or even let me discuss, patient may develop signs of Wellens type A and type B when left anterior descending artery is completely okay. How?
Prince metal.
It's very good. Prince metal angina, but if you have patient with 23, 24-year old young male and having taken large dose of cocaine. Cocaine is basically potent vasoconstrictor, and in coronary artery are very sensitive to cocaine. So yes, if there is chance if LAD spasm is too much, then patient will develop. You can say yes, you can say anterior wall ischemia, and there is chance patient will see the sign of Wellens type A and Wellens type B maybe, right?
So is it also fetal? That is it.
See, Prince metal angina is not vital because at the end you can say spontaneous vasodilation occur or calcium in spontaneous in Prince metal angina they are very well responded by the calcium channel blocker. You give sublingual nifedipine, then coronary artery will dilate. So yes, generally seen even MCQ they put you have a 40-year-old female patient in ER, and this is the ECG patient was having classical sign of chest pain and cardiac event. This is the ECG during the event. Then patient was treated with a sublingual nifedipine 5 milligram, and after a few minutes patient symptomatically improved. And this is the ECG. This is normal. Then what should be the probable diagnosis? Prince metal angina. Because females are more prone for the Principal angina. Yes, and calcium channel blockon cannot, you can say, cure ST segment elevation myocardial infarction. So, myocardial infarction was not there. That was basically due to intense vasospasm, and you give coronary artery vasodilator drug, that is nifedipine, vasoactive drug, and spasm relief, reperfusion start, patient sign and symptoms disappeared, and ECG became normal, right?
So sorbitrate won't work here.
Sorbitrate basically, specifically, it's a preload and afterload reducer, and it basically decrease the load on the heart or stress on the heart. Thus, basically decrease the cardiac work, and that's why it decrease the demand of the oxygen. This is how it is work. That is nitrates, right? Is there any question?
So whether in the side effect માં patient ને માથું ભારે.
Yes. Yes. Basically, what happens by sorbitrate dilates the basically artery and veins. So basically, arteries which is going to the cerebral, you can say brain, they also get dilated, and you can say at the entry point there are basically you can say pain receptor, and that area is very highly decorated with the pain receptor. The artery is basically dilated, then with the every pulse, that pain receptor will be hammered by the artery, and you will develop throbbing headache. Throbbing headache. It is, yes, if patient is having a MI and you want to reduce the workload of the heart, then at that time it is advisable. And this is the, you can, according to American Heart Association, this is the line of management. That is MONA. You know MONA? MONA, MONA. M for morphine, that is pain you can take as a tramadol. Here we usually give tramadol. Then O for oxygen, MONA, N for nitrates, and A for aspirin. This is a classical four drugs you need to give of a acute coronary syndrome patient. Acute coronary syndrome patient, right? Any more question? So remember MONA. Morphine or analgesic, generally we give tramadol. O for oxygen, N for nitrates, and A for aspirin. Right? Okay, fine. And yes, one more thing. If a Wellens type A or B patient undergoes stress, you can say, or yes, you go, we increase the cardiac work of the patient and see the that time ECG changes. That is stress test, right? So if stress is basically if done unappropriate, then there is high chance the patient will develop extensive myocardial infarction, or patient may go into cardiac arrest, because cardiac work is increased, oxygen demand is increased, and critically occluded LAD will not able to supply the increased O2 demand to the, you can say, dependent myocardium, and patient will develop extensive anterior myocardial infarction, and there is chance patient go into sudden cardiac death or cardiac, you can say cardiac arrest. So in this type of patient of Wellens syndrome, you basically need to take advanced care of the patient during when you are specifically doing the stress test. Okay. Okay, class dismiss.
Thank you so much.